clinical microbiology reporting. So so this particular session I usually take for my residents, first year residents, because when they come, they should not keep in their mind that microbiology culture report, the culture AST report, for most of the residents or most of the microbiologists, it is nothing but it is a ID plus the AST report. You report E. coli, like how Ketan has shown some of the earlier reports. E. coli sensitive to ABCD, resistant to GFEH. So not like that. So other than the ID and AST report, there are several other comments which we may have to give, because most basic lab, as I told you, the culture and AST report alone they report, and as a result, it doesn't help much to the clinicians. That is why, we have published an article also on this. This article was based on the classes of comments what we report in JIPMER blood culture section. So the blood culture division, we have various classes of antibiotic specific comments. So the comments what we report in our section are of various classes. So I will show you the classes of comment what we are showing. So these are the several pattern uh, um, of comments what we write in our in our blood culture report. So I will show you one ideal blood culture report, uh, how it can be. So I will show you the JIPMER model also at the end of the session. So these are the various classes of comment. I will not go into the detail of each of the comment, because most of these comments sometime or the other we have discussed yesterday and today in various CLSI sessions. So it will be summary of that. So the first class of comment is comment on various report categories. So these are the various. So I am telling you this whole comment based upon the blood culture report. So you can modify this comment to include the other specimens also. Okay. So the first report category is comments on various report category. So if it is a sterile report, then we send a comment like this: blood culture is sterile up to 48 hours. However, the total duration of incubation is 5 days, and if any growth occurs, will be updated subsequently. See, most of the clinicians, if you write that blood culture is sterile, they will not know that you are going to further incubate. So this further incubation point has to be incorporated into your comment. Sterile 5 days, you can tell that it is completely sterile. Then contaminated, you can write a comment for the contaminated specimen as ensure asepsis, so that they will do appropriate aseptic measures. Pathogen, you can write it as a pathogen, but if it is a pathogen uncertain, then you have to write that the pathogenicity of this, like for example, you are reporting BCC, you are reporting a Burkholderia cepacia complex, or you are reporting Acinetobacter non-Bowmani species. So those are more towards a contaminant also. The pathogenesis of those you are not sure. So if you want to report those pathogenicity uncertain organism, then we usually report them when they grow in a single blood culture specimen. We write that correlate clinically before start of antibiotic, send aseptically for confirmation. Okay. Then again, a very important type of reporting comment is giving information on what is awaited. Very very important. We don't do that. If you want to have something in your reporting later, then that particular information has to appear in the preliminary reporting. For example, if it is flagged positive, you write that it is flagged positive, the culture is under re-incubation. If you want to report the direct Gram-Stain report, then you have to write that the direct Gram-Stain report is this GNB or GPC. Identification is in progress and will be updated subsequently. If ID is available, you have to write AST will be reported subsequently. So if AST is in progress, so ID progress, AST progress, you have reported the AST, only colistin is not been reported. So so colistin AST is in progress. Or some antibiotics you are not reporting, then you write that breakpoints are not available, therefore we are not reporting. So like that, whatever you are doing and whatever is yet to be done, all those in progress reports, what is awaited, it is the duty of the microbiologist to inform the clinician about the informations of what is awaited. Third category is, in the culture requisition form, there are various clinical parameters must be available, like clinician's detail, location, diagnosis, source on the blood culture bottle, whether it is a central line or venipuncture sample, culture decision time, sample collection time, what antibiotic history is going on. So these are the clinical informations which need to be available. So we have developed a software. I mean, the next session is about the software only. So we are able to do all these type of comment possible. We are able to generate therapeutic index. We are able to generate so many comments together. The reason is we have developed an in-house software which is capable of artificially creating the comment by incorporating our inputs, and that saves lot of time, and that saves lot of time as well as effort also. So if these clinical parameters are missing, then what happens is our software will automatically add on the respective comments that these parameters are missing. Therefore you should make sure that uh, you should make these parameters available. Like for example, if source of central line or venipuncture source is missing on the bottle, then our comment is, when central line is present, kindly send one specimen from central line and other from the venipuncture. This will help to differentiate between contaminant and pathogen, and also to ascertain the microbiological diagnosis of CRBSI. So those kind of comments should appear if the clinical parameters are missing. Comments are related to specimen collection. If antibiotics are not if antibiotics are given before sample collection, though then if the specimen is collected after antibiotic start, then the comment should be like this: always collect the culture specimen before antibiotic start. If the patient is already on antibiotic, then the best time is to collect the specimen before the next dose of antibiotic. Blood volume, our own experience, we have started reporting blood volume in the report form from 2017 onwards. I mean, before this software also we used to report the blood volume to the patient. I think Deepasri has started this. So when we mention the blood volume to the clinician, we mention like this: if it is less than 8 ml, then we mention that the test is performed on less than recommended volume. Therefore you do not rely on this report, because our report may be false negative or false positive, because you have not given us adequate blood volume. So such informations, I remember we started this blood volume mentioning in 2017, and we have done an analysis also. We have published a paper on this. Over a period of 6 months, we have found that the appropriate blood volume is 8 to 10 ml is considered as appropriate blood volume ka percentage, nearly from 35% it got increased to roughly around 56 or 58%. So it was not a very big jump, because our clinicians are little resistant to advices. But however, we could do a reasonable statistical significant improvement in the appropriateness of the blood volume collected. Okay, the source of the blood culture also, if the source of the blood culture is not mentioned properly, or if they have given single sample from center line, single sample from venipuncture, then we can write the appropriate comments accordingly. I am not going into the detail of this because this particular article is available in Google also. You can go through this article. It is already a published article. Then comment on the footnote of the AST table. Always our AST table. Ketan has shown some AST table also in your therapeutic index session. So our AST table at below, always the expansion of SIR, all these will be it is always a part of our AST table. Don't think that SIR, all these are like so common that the clinician will understand by themselves. Even half of the microbiologists will not know what is the meaning of I. Yesterday we have discussed I stands for what, and we have seen that many of us have not answered the correct answer. So the meaning is, you can't presume that all these are understandable things. You have to expand this and you should mention what they mean.
One thing I like to add, for SDD, it is better to report the doses comment also. Like if you are reporting cefepime, suppose as a drug of
Right.
choice for enterobacterals, that is
Mm, that is
important.
that is the SDD comment is there upcoming in my future slides. So this is footnote in the AST table. Next is the as I told you, if susceptible to more than one antibiotic, then the Ketan's session we have discussed the role of therapeutic index and MIC guiding table. This can be a part of the comment. If resistant to all microbial stages, if you have a PDR isolate resistant to all microbial agent tested, then it is nice to incorporate 90-60 rule in your comment box, because 90-60 rule, I hope most of you will be knowing this. 90-60 rule says that for susceptible infection will respond to appropriate therapy in 90% of the time, whereas resistant infection, don't think that resistant infection will not respond to the therapy. Even the resistant infections also may respond to the therapy in 60% of the time. That is because, as Suchitra ma'am told, there are various PKPD parameters. There are significant other parameters which may determine the clinical success. Therefore, antimicrobial agent with the resistant results can still be considered. However, they have to make sure that the resistant antimicrobials should never be given for treatment if antimicrobials with susceptible results are available. 90-60 rule is not applicable if you have susceptible results available. Okay, then comments are related to site specific culture reporting. We always mention time to positivity in our culture report. Time to positivity we always mention, and we mention that lower TTP is associated with worse clinical outcome, and higher TTP is associated with better clinical outcome. You all must be knowing that for gram negative bacilli, a TTP of less than 6 hour, and for gram positive cocci, a TTP of less than 12 hour is associated with worse clinical outcome is associated with. So it is a prognostic marker. TTP is a prognostic marker, time to positivity is a prognostic marker, and this information should come in your clinical report. We always report TTP in our blood culture report. And of course, whenever we get CRBSI, we have a set of 4 5 comments. So these are the set of comment which we add to our culture report when we get CRBSI. I'm not going to read this. You can go through this article later. But in CRBSI, we also go to the bedside and we ensure that this comments are incorporated. They have been implemented in the patient care. In our every culture report, infection control advice is a standard advice which is incorporated. So most of the infections you need a contact precautions. So these are the respective infection control advices which we antibiotic uh, incorporate in our culture report. Next, coming to organism specific, I mean antibiotic related comment. Antibiotic related comment are so many types are there. We will not, I will not go into the depth because everything we have discussed throughout yesterday and today. So if it is MRSA, then we write the comment that avoid all beta lactam. If it is MSSA, then we write that cloxacillin is superior. Then Cefepime enterobacteriaceae, as Ketan told, we if we have whatever MIC value we get according to the dose we write. Okay, whatever MIC value we get, the respective dose we write. If it is SDD breakpoint, then also we mention the respective dose for Cefepime and enterobacteriaceae. We write infection control advices all, and there are repeat cultures we write if we have certain organisms which will come frequently. Okay, MRSA is yesterday we have discussed in Ketan ka session. MRSA vancomycin, if MIC is more than one, then this is the comment we write. You consider alternate therapy because vancomycin MIC is towards the upper end of susceptible breakpoint. Renal adjustment comment always appear along with the renal toxic antibiotics like vancomycin, colicin, and amikacin. Yes, this we discussed in the previous session. Colicin warning comment. This set of comments are always a part of our culture report whenever we report colicin. Okay, predicted susceptibility related comment. This we have discussed so many times yesterday under we have discussed this under equivalent agent, then surrogate marker. All this we have discussed. So whenever any predicted antibiotic, whenever any antibiotic with the predicted susceptibility report is available, always like if for enterobacteriaceae, if you are reporting ceftriaxone, our by default comment is ceftriaxone can be extrapolated for cefotaxime. So like that, all these predicted susceptibility related comment also we add. So this is the continuation of the same table.
Can I see the previous slide again? Cholesterol one.
Okay.
Yes.
Yeah. Thank you. Then intrinsic resistant comment. Yes, Harita's session we have discussed what are the various intrinsic and resistant comments. So don't presume that clinician will know what are the drug they are intrinsically resistant. See, enterobacteriaceae, it is humanly not possible because these are the whole list of antibiotic to which enterobacteriaceae is intrinsically resistant. In addition, for Klebsiella, these are extra antibiotics. Citrobacter, these are extra antibiotics, and so on. So this is always a part of our comment. But we have a intrinsic resistant comment box where the list of antibiotics will appear, and we make sure that the clinicians do not use those antibiotics. Okay, so this is the continuation of intrinsic resistant comment. So there are various type of comment box. Now I will tell you the two stage reporting what happens in UK model of two-stage reporting. See, so as now you know that there are two type of our microbiology reporting in blood culture section can be broadly be divided into ID plus AST generation and adding all the antibiotic comments plus verifying the ID and AST data. So these are the two broad category of work. So we are following like a close to the UK model of two-stage reporting. So this is our blood culture section. So broadly we have divided ourselves into two groups. Group A, team one comprises of a technician, a junior resident, that is MD microbiology resident, and a senior research fellow. He is a project staff. So So and sometimes some MSc or BSc student also may be available. So this is team one. The role of team one is they will uh, they will verify the plates and they will keep ID and AST. They will make it ready. They will note down the zone diameters, and and also they will uh, do all the basic level of technical work. So okay, so ID and AST are generated by team 1. Then team 2 comprises of myself, then Ketan, and if one more junior resident is there, then usually one junior resident will be posted. If one is posted, he will be included in team 1. If two are posted, then the second one will be included under team 2. Team 2 role is Team 2 role is, as I told you, we team 2 role is verify each and every work of team 1 step by step, like the ID and AST how they have generated is correct or not, there is no contamination, all that you verify, and then do the reporting in the system. So we work on the software to generate the antibiotic report by adding various classes of and various classes of clinical microbiology reporting comments. Okay, so this is how we do our reporting. So kind of two-stage reporting. Actually, UKMA they do two complete stages of reporting. Like the technical team will be inside the lab and they will be doing the reporting, and the clinical microbiology team. The our two teams are we call the two team as technical microbiology team and clinical microbiology team. So this is how we designate. So in UKMA, the clinical microbiology team they completely work in a different chamber, and where through the system they can see the culture plates and the AST report also if possible, and they generate the report. Ours like our workplace is same, but our work category, the work type we have divided among ourselves. So the blood culture workflow goes like this. After the sum, so we make sure that our turnaround time is always taken into consideration. We make sure that the turnaround time is as low as possible. So we have kept some check mechanisms. After the sample received, the blood culture bottle has to be loaded within 10 minutes, and when it flags negative, the auto generated report, our software generate auto generated report without my signature. Like we have made a rule that at 48 hours and at 5 days the auto generated flagged reports will directly go to the clinicians. If it is if it is flagged positive, then we do the following: gram stain, DST, and then the subculture. And the gram stain report, based upon the gram stain report, the DST will be put. And after 8 to 10 hours, we put the identification and we generate the ID and DST are clubbed together, and the preliminary report is generated. So our preliminary report time is time to positivity plus roughly around 10 hours, you can say. Time to positivity, how much time the machine to flag positive, plus 10 hours. So roughly our preliminary report turnaround time of blood culture is 20 to 24 hours from the time of receipt. So this is our preliminary report turnaround time. And the next day we give the colony biotech, antibiotic advices, therapeutic index, all these we incorporate and we give. So this takes another 20 hours. So roughly around 40 to 48 hours time we take to generate the final report. Our reporting happens 24/7. I would like to take on the opportunity to say that my residents A started with Dipasri. She has introduced two double reporting in our section. Like we started reporting instead of, so earlier we used to report only morning 9 o'clock. That was changed during Dipasi's time. We have started early reporting. 7:30 we start the reporting, and so that I mean the resident will go will come at 7:30. 8 to 9 we will finish the reporting, so that 9 o'clock when the clinicians will come for round, the reports will be available to them, so that that will reduce the action taken time to great extent. Okay, so our reports usually get generated, and it goes to the clinician's mobile before they start the round. So this is one time of reporting. Then again a evening reporting we do, again a evening reporting we do at 4 to 5 p.m., where the second stage reporting we give. And after the evening reporting also, we do something called as live reporting. Live reporting was a concept I dreamt when Deepasi was there, but I could not implement that time. However, after she left, Harita joined, and the software was in place. After the software was in place, we started doing live reporting. Live reporting means whenever Vitech will give a report, we will make sure that the report goes to the clinicians uh, immediately, because it is a software based reporting system. Even if the senior resident is there in the hostel also, she can coordinate, and she can generate the report. So this is called as live reporting. Okay, holiday reporting also we was started when Deepasri was there. So this is the way we reduce the turnaround time to as low as possible. So this is the culture we do by Bacteria Alert and Virtuo, identification by Maldituf, and AST by Vitech, and of course colony AST we do by Vitech, but direct we do by direct disk diffusion. Okay. Okay, we have created AMSP WhatsApp group through which we report to the clinician. Our residents on day in and day out, they communicate with the clinical residents. So AMSP subgroups are there: AMSP MICU, AMSP pediatric, and so on. So our resident, they keep on interacting with each other. So this is not a new group. This group is there when Deepasi was there. So maybe 2018 onwards, this group, 2017 onwards, this group was created. Okay. So now I will show you our blood culture report, how we give. So when we generate the blood culture report, we send a auto generated message to the patient. So SMS, auto generated SMS. When we authorize, I repeat, when we authorize, a auto generated message goes along with the link of the PDF. So the clinic, and also the brief comment also can go along with that. When the clinician will press on the link, the PDF will open. So the PDF will have around 4 pages. So this is page 1 and page 2. Page 1 we will have demographic information, then blood volume information, time to positivity, direct gram stain report, and organism name. And page 2 will have antibiotic report. This is a preliminary report. Therefore direct susceptibility test or DST report is been incorporated with a specific comment that Vitech AST is in progress. Along with that antibiotic specific comment, infection control advices, the incomplete form filling comments, all these are generated. So this is a preliminary report which goes with the DST report. The next day we send the final report. Final report, the page 1 is same. It will have the same information. However, page 2 will have the Vitech information. Vitech information as Ketan showed, line, then MIC value, then the interpretation along with therapeutic index. Page 3 is our MIC guiding table. So to explain about the therapeutic index, we always incorporate MIC guiding table. Page 3 now we will have antibiotic specific comment as well as infection control advices. And of course, page 4 will have the incomplete form filling advices, and the signature form. So this is how our so this report gets auto generated. So we have a software demonstration. Now I can show you the software demonstration also, like how we generate the report in the software. If the internet works well, then I can show you. Otherwise, the session is over. Maybe another 10-15 minutes we can wind up as I can after I show the software to you. Okay, one important part of our blood culture diagnostic stewardship, what I didn't tell you is, every day after the reporting is over, our reporting starts at, I mean, the resident comes at 7:30. The reporting starts at 8 to 9. After the reporting is over, the microbiology resident, okay, along with Dr. Ketan, they go for something called as pathogen directed AMSP round. Okay, the pathogen directed AMSP round, where they discuss with the clinicians for all the positive blood culture report, the reports what we would have sent to them just half an hour back, all those reports they give, and they ensure that the antibiotic advices, whatever we have advised, they will try to ensure that those are implemented. Okay, so because always pathogen directed AMSP round should accompany your culture report, so that the impact will be, just by sending to the clinician is not equal to clinician reading the report. Don't consider that sending the report to the clinician is equal to clinician reading the report. If you club this activity in addition by doing a pathogen directed AMSP round, that will enable the clinician to act on your report. Okay, so this is all about the session. Now I will try to demonstrate the software. We have finished today's session completely, all the topics. Unlike yesterday we skipped few sessions, today we try to finish all the sessions, and on time. We are just about to reach 2 o'clock. So on time we have finished, just only the software demonstration part is there. So I want to know, can I share my screen, Neeraj?
Yes, sir.
Yes, sir,
Yes,
yeah,
sir.
you are already sharing it.
Screen.
So your screen
Please
already.
unshare and then try again.